So this next session will be about SFA treatment options, and our first speaker is going to be Mehdi Shishehbor to talk about segmentalization approach for femoropopliteal intervention.
Thank you very much, Dr. Nazar. And thanks for everyone who is attending. I want to kind of be a little bit provocative in this section. You know, sometimes, when we treat the long SFA popliteal and you have made up your mind what device you're going to use, we tend to stick to that device. And I just want to be a little bit provocative and give the idea that is it possible in the same segment, in the same artery, can we use 4 or 5 different devices depending on the anatomy and the features. So let's start with this case. This is an 87-year-old status post recent CABG, CKD, diabetes, and aortic surgery. Comes in with this pre-ischemic lesion in the toe and is having significant pain. You can see that it's a flat waveform and an abnormal ABI. Patient obviously has extensive vascular disease. The common femoral is fine. The proximal SFA is okay, but there's extensive disease with a totally occluded P2 and P3 segment with reconstitution here of what appears to be AT and the tibioperoneal trunk, but extensive collateralization also at the distal edge of the occlusion. So in this situation, we tried the antegrade approach and we were not successful, and that's not the point of this presentation, but I think I want to highlight that what do you do when you go through these challenging cases? What are your choices? So we had to get retrograde access, and we get a retrograde access, but even that was not easy because we had done so much damage from the top. And we kept going to the wrong place. And you can see here when we injected, we realized that this was the wrong place, but the right place was actually where the arrow is. So that's the benefit of doing retrograde injection. It's actually something that we should do frequently to try to understand the anatomy. So now that we understood the anatomy, we're able to bring a 4 French GR4, cut the tip so that we can get better engagement, and we are able to cross the lesion. And we crossed the lesion. We were subintimal at the time. So now we have to get re-entry. So again, the same techniques we discussed yesterday. We did, cart, reverse cart, parallel balloon, and we are finally able to get through the lesion. So we get through the lesion, and the question becomes now, and I apologize for this, what are you going to do? You had extensive work. You went antegrade, subintimal. You went retrograde. So what are the options in this situation? Do you want to put a drug-eluting stent? Is a popliteal segment? Do you want to do a drug-coated balloon? And I will show you the angiogram. Do you want to do a supera interwoven stent given the calcification, given the location? Do you want to put a covered stent or do the crack and pave as we saw it yesterday with Andre? Or do you want to just stay stent-free, no metal behind? Do you want to stick to a drug-coated balloon or even do angioplasty, which is in this day and age with the amount of data we have with drug-coated technology, I think is no longer, it should be in our armamentarium as a standalone therapy. So in this situation, we decided to go with a supera, and this is our final result with a 2-vessel runoff, and the patient did well. So what are the choices? So I'm not going to go into detail because the panel is going to discuss all the different devices at length. But we have 5-year data with the drug-eluting stent, so we feel good about that. We have DCB, 2 devices that are approved. We have 3-year data, and we have patency that are in the range of 80%. So we have excellent data with DCB, excellent data with drug-eluting stent, and we have supera that now has 3-year data. But the paradigm shift of putting no metal behind and using drug-coated balloon, while interesting, has also opened a slew of other options. So you can do DCB alone. You can do atherectomy plus DCB, as we just discussed in the last section. You can do DCB plus spot stenting. You can do DCB atherectomy plus spot stenting or using a TAC technology. So there's so many options. And the DCBs obviously have changed the way we treat these lesions, especially the femoropopliteal segment. But we know that DCBs also have limitations. So how do you balance that in this 30 centimeter, 40 centimeter artery? We have dissection, recoil, there is significant calcification, and the question is, as Thomas Zeller puts it, is this hope or hype? I think there's been some hope since he published this editorial, but also there are challenges. And something that's very interesting, I think this is probably the most important slide of my presentation, and that is that we subjectively have moved to this idea that if you don't have flow limiting dissection, things are fine. And to me, that's such a subjective, a marker of patency, especially if you're treating patients with claudication. And I think this study really brings it to highlights this issue of residual stenosis, and this is a coronary study, but they basically looked at residual stenosis by FFR after stenting from the edge of the stent. And they showed that even minimal, none of these are significant for us, because remember, for coronary arteries, 0.8 is significant. But even if you have non-significant graded FFR, graded pressure across the treated lesion, the patency was 44% in those patients compared to those that did not have a residual gradient across the lesion, even though that gradient doesn't appear to be significant based on the decision we make on treating these patients. 44% binary patency versus 8%. So I think we need to be more objective in treating these lesions and saying that there is no flow limiting dissection. So from the issue of segmentalized approach, so why I bring in this concept before we go through these devices, is that in my mind, I think we need to move beyond just, this is the SFA, I'm just going to put this device because I selected this device. We should look at the degree of calcification. We should look at the location. Is it popliteal or osteal SFA? If it's osteal SFA, maybe I shouldn't use Supera. If it is popliteal and is heavily calcified, well, maybe that's a good option. And now we have other options. Maybe I should do the crack and pave, as Andre showed it, to get the optimal result. Is it a stenotic or occlusive? If it's a stenotic, well, I can maybe do a atherectomy. I can do a decent atherectomy, get less than 30% residual stenosis, and then deliver DCB. If it is totally occluded and I'm subintimal, well, that may change my algorithm, because I know I cannot do very good atherectomy when I'm in a subintimal space. And then each segment may be different. You may place a Supera in the popliteal calcified lesion, and then you may follow that with some DCB. And if you get a dissection, you may put a nitronal stent, regular nitronal stent, as a spot stenting. So again, I think you should use your armamentarium depending on your patient characteristics, the lesion characteristics and location, and the degree of calcification, and hopefully one day even the morphology of the plaque. So in one vessel, which is the femoropopliteal segment, you may end up with 3-4 different devices rather than picking one device at the beginning of the case and deciding I'm just going to go with this particular device. Thank you very much.